I think our ER staff have always been very aware of the situations and needs. They feel excited when they think they're going to deliver a baby down there, but they don't necessarily know. They know that they're not going to be alone in that process. So it's just more of a witness and assist, kind of thing. I'm Jennifer Esparza. I am a labor and delivery nurse for 21 years. I would say we had a lot of disconnect. There was not a lot of collaboration. And this is before our Texas AIM really had a big focus on the maternal mortality factors. The collaboration with the emergency department and staff there, as well as directors and management, really improved for our patients' care. They see patients that may have seizures due to high blood pressures, preeclampsia or eclampsia at that point while still pregnant, or even in a postpartum setting, and evaluating the patient in a quick triage moment to determine where the direction is going to be was necessary. So utilizing the Texas AIM bundles regarding preeclampsia, hypertension in pregnancy, pregnancy care in general was where we were looking at the possibilities of where we could find problems that could be evaluated quickly and their path of care. Once they received that phone call from EMS was straight to us, and they call either our hospitalist or charge nurse, or one and then the other, because then we're able to utilize, mobilize our team into their department, knowing that the arrival was going to take time from where they were to come to us. They were able to get more staff available in that area quickly once that patient arrived there. So it was definitely a collaboration that was very, very aware. I think our ER staff, even though we're a community hospital, have always been very aware of the situations and needs. They feel excited when they think they're going to deliver a baby down there, but they don't necessarily know. They know that they're not going to be alone in that process. So it's just more of a witness and assist, kind of thing. It's a lot of more of a delegation thing, which I think my previous manager would always tell me that was my major issue to work on, as my major weakness, because as a nurse in labor and delivery, working to care for the patients, and especially an emergency situation, is just an instinct. However, I can't go and run to get the supplies if I'm in the middle of doing certain things for the patient and evaluating, or maybe assisting with intrauterine resuscitation for baby or something like that. And utilizing the staff that I have to be able to help manage my patient is always important. Possibly several triage patients, in a row. It is getting one assigned to another nurse so that they can continue, so I can continue evaluating those OB triage patients as well. And really, in that regard, it's more of a delegation concern. They're all educated and well enough, trained well, especially the ones who are newer nurses, to be able to handle the things that are more, emergent evaluation kind of things. But they are necessary to be managed in that, and then as well as supported, because sometimes it's more of an emotional thing that can cause them some emotion and stress. So being trained as a responder for emotional trauma is also a big part of that too, I think, as a leader. I think, forming your team and trust and respect amongst each other is number one. You kind of know what their skill set is a charge nurse. And so evaluating who you have with you, knowing what their strengths and what their weaknesses might be, also assisting them to find a way to work through those weaknesses as a team. It helps them to build that skill set of encouragement, of positivity, of cohesiveness, all of those things together. My weakness of delegation was really, it's just a process in my head was, okay, I have 3 patients. I can hand off one to someone else. I have one patient who needs an IV. I can ask for some assistance to get that IV started. Those kind of little things in my head where my original mindset was always do it myself. It's not a problem. Some days are busier days. We're a small unit, but if everybody has one patient, they can hand off something to another person to be able to assist when there's more of an emergent need on the unit itself. And I think that our team has really built itself in assisting for the patient's need, and what comes first is the patient's. So if one person is having an issue in their room, calling for another nurse is necessary when they're needing that assistance. And the same goes in regard to our ER area, where if there's several patients there, one person can assist for watching over the ones who are more emergent or less emergent, or already stable. The staff in the ER, they're triage area is very aware. They have algorithms, those kind of things that they're going to look at. If they see a patient is pregnant, or they realize the patient is pregnant once they've gotten their little small in-the-door triage going, they immediately call us to let us know the history and the SBAR for that patient. And we either are aware or need to go and receive them ourselves, depending on the situation for the patient. If they see a patient come in, screaming, crying, whatever it is, and evaluate that that's the need, they may call us down to come and evaluate and assist. And once we know they're either delivering right there or they're able to be transported up, then we'll handle that together. Most often, they have a little bit more staff than we do when there's, because ER's ER and they go crazy, but they have patient techs and transport available to them and those kind of things a little bit more readily than we would. And our floors are completely opposite from each other. So, knowing if we are in need of that assistance for them to transport, or we can go and get them and evaluate as we go kind of situation. It's just a case-by-case situation, but they do work really well with us in the communication factor, both to our charge nurse or unit and to our hospitalist doctor who is caring for OB patients. Texas AIM puts out different bundles over the time frame, as well as A1 providing guidelines for those care. Preeclampsia patients who are having issues with high blood pressures. If we're seeing it in a certain range, we know that we're going to be doing medications within 30 minutes to an hour at the most, to make sure that we're not causing the patient more harm in getting their treatment going faster. Evaluation by the physician within a certain time frame, depending on this patient's severity of need. What we call Muse triggers, those maternal early warning signs. With maybe like with we're talking about preeclampsia, we see elevated blood pressures, headaches, signs or symptoms that are causing a severe concern, and they fit within this little algorithm to make sure that we're getting treatment within a certain amount of minutes. We are evaluating that patient within a certain amount of minutes. We are making sure that patient stability is reevaluated as we go through treatment. So all of those we talk about hemorrhage in a patient setting where maybe the patient has arrived with heavy bleeding, either pregnant or not, or previously delivered, when we're concerned about their loss of blood. And so there is the same thing. There's an algorithm to know we're weighing our amounts, qualitative blood loss, so that we can evaluate where we go in that pathway. Are we giving blood? Are we transfusing? Are we just stopping the bleeding, or just not just an evaluation situation? Or are we delivering the baby if she's still pregnant, and making sure that patient is stabilized for those kind of things. We always work with our other departments, like our ED department, because they're that first opening door where people walk in at times, especially in the middle of the night. Clearly they have a lot of different type of patients that come through the door. Ours is just a piece of that. And making sure that they are up to date with our bundles. They have the notification across the board to their staff from the management on down. Not just them, but also our patient access representation to know if they're handling their chart correctly and their billing and those kind of things. There's a lot of little factors, because that comes into play for not just our patient care, but also our revenue and being able to continue to care for our patients. It is important from all the aspects of patient patient care, not just monetarily, following their process of information, but also for the care itself. And so making sure that that streamline continues and there's not a Swiss cheese concern. But we follow through with every case study. We have a quality group that makes sure that when there are specific things that are not followed in a process, whether it be drug abuse intervention or, an event that happens for a patient with their care or their process of care regarding their health. There are random things that happen, and making sure that that quality group continues to follow through. The only thing I think that maybe an improvement might be needed, it's really just that consistency of education. And we're working at that as well. We've had some changeovers in staffing for our education department recently, and we know that that becomes a problem when there's not consistency and communication across the board. But we are all very, in the small of our leadership, it comes from, management, directing management, coordinators down to the charge nurse groups. I think we work really well together in making sure we're not missing the things and we don't miss the pieces as they go. And we follow through, we follow up, and just kind of checking in with each other, not just for our patient line, but also our own mental health. Prioritization is huge when you're looking at trying to solve some problems. There's a lot of little ones that can add up to big ones, but if you look at the big ones, look what your gap is, where are the problems that you see that are immediate that you can fix, and what are the long-term ones that would take a lot of collaboration for other teams, management, who are your stakeholders in all of those pieces that are not just patient relations, but if you're looking at monetary issues and concerns for your budget that would qualify you to make bigger changes, find the stakeholders that are there. Look at your bottom line of concerns, but prioritize the needs. What are the ones that are the biggest things that are going to make the biggest impact? And find a stakeholder that's going to really help you buy into the problem solving factors. Utilize your hospital representatives that you can. Not all clinical staff is focused and responsible for certain aspects of your care. The research behind what is improving our patient care and even our clinical practice. Those are two big things that are going to get us to where we can improve all outcomes, even our own, maybe our own clinical guidance.